So once someone has been diagnosed with a basal cell carcinoma and the specimen has been submitted to the lab, the pathologist will tell us information about any high-risk features that may be seen in the specimen, such as the differentiation of the basal cell or whether or not there's any involvement of the nerves or perineural invasion. And once the diagnosis of BCC is made, then we kind of stratify the basal cell carcinoma as low risk for recurrence or high risk of recurrence after treatment to then determine what is the best approach to managing it. So features that we look for or that we take into account when determining whether a BCC tumor has a low or high risk of recurrence after treatment include the location on the body and the size of the lesion. So basal cell carcinomas that are located on the trunk or extremities, that is excluding sites like the face, the genitalia, the hands or the feet, or the shins, so the pretibial surfaces. And those that are less than 20 millimeters, so less than 2 centimeters on diameter, those are considered at low risk for recurrence. But additionally, they also need to have no high-risk features under the microscope, so pathology should not demonstrate aggressive histology or perineural invasion. And then other features that would make a basal cell carcinoma at low risk for recurrence include a tumor that is primary, meaning it hasn't been treated and has not recurred. The tumor borders are well defined to the naked eye. There's no history of radiation at the site where the basal cell carcinoma has been diagnosed, and the patient is otherwise healthy and not immunocompromised. So how to manage a basal cell carcinoma that's considered at low risk for recurrence? Oftentimes we'll proceed with a standard excision. This is done in the office, in the dermatologist's office. We will remove the tumor with a margin of normal skin, and usually we choose about 4 millimeter margins of normal skin on each side of the tumor to remove it almost in an ellipse shape and submit that to the pathologist for processing of the tissue and for evaluation of the margins. Another option may be a procedure that's also done in the office called curettage and electrodesiccation. This is done after numbing of the skin, similar to the excision. The tumor site is marked, and we use a sharp instrument, almost like a looped blade, to remove or to scrape the top layer of the skin that may still contain basal cell cells, so carcinoma cells. Afterwards, after the scraping is performed, we use heat to stop any bleeding in the site. These are options for patients who have low-risk basal cell carcinoma, and after a discussion with a dermatologist and depending on patient preference, an excision or a CNE may be pursued. The curettage and electrodesiccation oftentimes will result in a circular scar, so the cosmetic outcome may not be as good compared to an excision, but it's always an option and something to discuss with a dermatologist. For someone who does not want to proceed with an excision, or if they have other risk factors, other options that are non-surgical for low-risk basal cell carcinoma include topical therapies. We have 2 creams available, imiquimod cream or fluorouracil cream. That may be applied at the site where the basal cell carcinoma was diagnosed. They do often require long application, so over the course of a few weeks. In the case of imiquimod cream, we generally recommend nightly application of the cream to the site, Monday through Friday, taking a break usually on the weekends for about 6 weeks. This can lead to irritation in the site, as well as some redness, erosion, and in some severe cases, it can lead to more systemic symptoms, usually flu-like symptoms. Another option as far as topical therapies is fluorouracil cream or solution. Fluorouracil 5% cream is also applied to the site where the basal cell skin cancer has been diagnosed, typically twice a day for about 3 to 6 weeks. Similar to imiquimod cream, it can lead to irritation at the area, as well as crusting or an eschar formation at the site. Those are options for patients who want to avoid surgery, or if they have a very thin, a very superficial and small basal cell skin cancer, where surgery may not necessarily be indicated. Alternative non-surgical options include photodynamic therapy. This is done in the dermatologist's office, where we apply a photosensitizer to the affected area, usually done in the setting of field therapy. We allow that to incubate for a few hours, and then the skin is exposed to blue light. It is associated with redness as well as increased sensitivity to the sun, and generally after photodynamic therapy or PDT, we do recommend sun avoidance for about 48 hours after the procedure, so as not to induce photosensitivity when the patient is outdoors. Alternative non-surgical management options for low-risk basal cell carcinoma include cryotherapy. This is liquid nitrogen therapy, again, performed in the office, where we're essentially freezing or destroying the site of the BCC. It should be reserved, again, for low-risk tumors, so thin superficial basal cells at low-risk areas, so the trunk and extremities, not on the face. And it can sometimes be associated with post-treatment scarring, especially lightening or darkening of the skin. And then lastly, for patients who are non-surgical candidates or who otherwise are trying to avoid creams or are trying to avoid surgery for treatment of their low-risk basal cell carcinoma, radiation therapy can also be considered. There are some side effects to radiation therapy in the acute setting, including redness or burning, but also some more later side effects on the skin, such as loss of hair in the area or pigmentary changes. And then some radiation therapies can also be associated, as we mentioned, with an increased risk of a secondary malignancy at the site. So these are all discussions to have with a dermatologist once you have been diagnosed with a low-risk basal cell skin cancer. And none of these approaches are one-size-fits-all. Oftentimes we take into consideration the patient, the site of the basal cell, again, the pathologic features to determine what is the best management option.